key topics in asthma and encourage each of you to actively participate and engage with the content. Now I invite Chairperson, Indian Academy of Pediatrics National Respiratory Chapter, Dr. N.K. Kalpanwar, for formal welcome message.
Thank you, Dr. Jagdish. Good evening, all. We have a very special day for us today. As you know, today we are celebrating World Asthma Day across the world. So in this occasion, even the Indian Academy of Pediatrics National Respiratory Chapter is also celebrating, and with a special note, we have a very eminent personalities. You all know that the theme of this year's World Asthma Day is Asthma Education Empowers. We all believe that everyone should be aware about, and knowledge about the asthma is very much important. And we always teach, we should teach more than what we treat in asthma cases, because if the patient knows the course and the complete disease pattern, then it is easy for him to handle the disease. So in that context, we have a webinar today, and this webinar is very special for all of us, and this is going to enlighten us regarding the burning issues regarding asthma and today's situation. For this occasion, we have two eminent faculties, and you all know them, but it is formally on me to introduce them. First of all, I take this opportunity on behalf of myself and Indian Academy of Pediatrics, welcome none other than our own person, Dr. Varinder Singh. Sir, on behalf of all of us, I welcome you for this function.
Thank you. Thank you.
I take this opportunity to welcome another important international eminent personality, and he is a legend in the field of pediatric asthma. He is none other than Dr. Andrew Bush from London. Sir, I take this opportunity on behalf of myself and entire IAP team, welcome you for this function.
Thank you so much. I really appreciate the invitation and the chance to be here. I really appreciate it. Thank you.
Thank you, sir. I take this opportunity to welcome my senior colleagues, the President-elect, Dr. Sanjeev Rawat, and the immediate past President, Dr. B.S. Sharma, and our Honorable Secretary, Mr. Dr. Jagdish Goyal, and the Treasurer, Dr. Mukesh Gupta, and the entire EB for this very, very important webinar of the IAPNRC. I also take this occasion to welcome all my delegates who are eager to learn from the eminent personality, and I welcome you all, and I wish a very happy, and you will definitely have a feast of academics in the next 1 hour. Thank you very much, and over to Jagdish.
Thank you, sir. Thank you. Now I invite Dr. Neetu Talwar, who is moderator for today's session. She is consultant pediatric pulmonologist at Fortis Hospital, Gurgaon, and she is also executive board member of IAP National Respiratory Chapter. May I request Dr. Neetu to kindly introduce today's speaker and kindly take over the session. Dr. Neetu.
Thank you so much for the kind introduction, Dr. Jagdish. And it is indeed my proud privilege to welcome and introduce amongst the most distinguished pediatric respirologists. And I welcome both of you, sir, Professor Varinder Singh and Professor Andrew Bush. And they are known for their excellent contributions to the field of pediatric respirology. I will now share the screen to read out the introduction of the first speaker. Professor Varinder Singh, he needs no introduction. Sir is the Director, Professor Pediatrics and Lead for the National Center of Excellence, Pediatric TB, Department of Pediatrics, Lady Hardinge Medical College, Kalavati Saran Children's Hospital, Delhi. Sir is the lead of the National Technical Expert Group for, part of the screen is not seen, for Pediatric TB for NTEP India. Sir has made his great contributions to the government of India and has helped in formulating the IAP guidelines on a variety of important topics: asthma, tuberculosis, COVID management in children. Sir has several papers to his credit, written many chapters, and contributed in many books. Sir's special interest is in pulmonology, interventional bronchology, tuberculosis, rational antimicrobial therapy, research methodology, and innovations in health. I welcome you, sir, and sir will take the first session, and that is assessment of control of asthma in children. Over to you, sir.
I hope my slides are visible.
Visible, sir.
Okay. Just give me one. So it's indeed a great occasion for me to speak on and share the platform with Professor Andrew Bush, who has been my mentor and who has helped me a lot in learning more about asthma and learning respiratory care with humanity in mind. And that's his forte. There are many other experts in respiratory care, but his human touch and his connect with the resource challenge world is something which is very remarkable. So I'm glad to be sharing dice with him. And thank you to the organizers for having invited me today to speak on this World Asthma Day in 2024. So I'm going to talk on assessment of asthma control in children. And the plan of my talk is some of us who carry the legacy baggage have struggled with the severity and now the current guidelines talking about control. So I do realize that in addition to the several youngsters who have joined, there are several seniors also who are there. So we'll talk about this change in concept from severity to control and how does it matter. What are the tools for monitoring control? What are the clinical relevance and how do they affect the monitoring? So three conceptual points I want to bring up when I start with assessment and monitoring of asthma: severity, control, and responsiveness. So when we say severity, we're talking of an intrinsic intensity of the disease process. And it is most easily and directly measured in a patient who's not receiving any long-term therapy as of yet, which is many a time not the case, because when the patient comes to you, they are already on some kind of treatment, adequate or inadequate. So in those situations, perhaps, and that's perhaps the real life situation, that severity is often inferred once the asthma control is achieved by the step of care required to maintain control. But these concepts by themselves are dated. We do realize that the severity of asthma is a dynamic process and it changes over a period of time, despite or despite. On the other hand, the concept of control is more of a clinically relevant situation which talks of degree to which a manifestation of asthma symptoms are minimized by the therapeutic intervention and the goals of therapy are met, that the child is able to live as normal a life as possible with a normal pulmonary function. And the concept of responsiveness is ease with which the asthma control is achieved. And if the responsiveness is good, then we know the steroid, the severe therapy resistant asthma and other concepts come in. Going further, when we talk of asthma control, the two important domains which are used is one is the impairment, which is the frequency and intensity of symptoms and functional limitation which the patient is experiencing at this point of time or recently has experienced, and then that decides what therapy perhaps is most suited for this patient going further. This may further be, affected by the likelihood of asthma exacerbations or progressive decline in lung function, called as risk, or sometimes also governed by risk of adverse effects for medication if you are on step 5 or step 6, where you really want to tailor your goals of therapy so that it best achieved with the minimal risk of certain adverse events. So the earlier grading of severity was based on symptom of airflow obstruction, nighttime symptoms, weak expiratory flow rate, and divided into intermittent, mild, persistent. And this has evolved with time, where people have stopped saying intermittent as a mild intermittent asthma, because you can have a severe exacerbation even when your disease otherwise is intermittent. So that mild word has been dropped. And then you have asthma, which is mild, moderate, or severe, depending on what level of therapy you're required. So that's how the severity is defined. Why this change has happened in the treatment goal, or from severity, why have we moved on to control? So one of the things which impacted this was that we thought that we had enough armamentarium with us to reduce the disease severity or decrease the long-term changes, and which we realized perhaps is not the truth. What you can actually do is you can improve a long-term prognosis by achieving a better control and reducing the burden of asthma, depending on even the risk of the exacerbation to the patient. So this clinical shift has led to a difference in clinical use of the concepts of severity and control. Severity is largely used to initiate therapy. When you see a patient at initial presentation has not been currently taking any long-term medicine. So it could guide clinical decision for appropriate medication required at that point of time, while control is largely about adjusting therapy. So once the therapy is initiated, adequate or inadequate, by you or somebody else, the emphasis for further clinical management is changed from assessment of the severity, the background disease severity, which is going to be difficult to measure, to assessment of asthma control. And this level of control will guide your decision whether you want to maintain or adjust, step up or step down the therapy the patient is already on, depending on the amount, the type of control achieved. So the severity largely was based on you have intermittency of symptoms, which was less than 2 times daytime symptom per week, or less than 2 times nighttime symptoms per week, and occasional less than 1 exacerbation per year, or increasing severity from mild to moderate, where it went from more than 2 days per week to daily to almost all throughout the day symptoms, or a weekly to more than a weekly nighttime symptoms, and likewise uses of SABA and interference with the normal activity. And that guided the steps 1 and 2 and 3. And we are very familiar with the recommended therapy at various steps. These are a good beginner and help for most of our patients. So there are situations where you would like to go beyond. So if asthma control is about using your therapy to the best, to get the best control of symptoms, then it has to be a continuous cycle of monitoring to match treatment to the control. Because you are aiming to obtain asthma control in a life with no or minimal impairment, and you would like to achieve that control at a lowest step of treatment and dose of treatment to minimize cost and reduce the possible side effects. So how do we assess asthma control? It can be assessed using many indices, the commonest one being symptoms and medication use. And then we have activity limitations. And then there are more, these are more subjective, and you have more objective surrogate measures like lung function, inflammatory markers reflecting the underlying pathophysiology, like an exhaled NO, or a sputum eosinophil, or other biomarkers, or immunological mechanisms involved in the disease. Aspects of the disease that are treatment responsive particularly need a close attention on what index we use for assessing control. And that largely goes to symptoms or lung function and not necessarily to inflammatory marker, as I will discuss a little later. So the components which are really very relevant to assessment of asthma control are obviously frequency and severity of symptoms, or a change in lung function or level of bronchial hyperreactivity, or reaction to this environmental or other triggers or stimulus, which may exist in various combination in different diseases. So therefore, these often form the mainstay of assessing the asthma control. Control based on measures of inflammations like sputum eosinophils or exhaled NO likely to differ from control based on clinical measures or lung function or BHR because they do not go absolutely in a hand-to-hand fashion in a linear way. And there is very limited evidence to say how these characteristics can be integrated, these measures of inflammation for monitoring children with asthma. Recent exacerbations and oral corticosteroid use is also an important future risk which we have to keep in mind when we are looking at symptom control. Several tools have been used, and this is a very nice guideline by ERS on assessment of for monitoring of childhood asthma, which came up in 2015. And they have looked at what tools are available at different ages. And obviously, you can't use the same symptom monitors or tools. The idea of these clinical tools, like asthma control test or asthma control questionnaires, is to get some objective measure of something which is more subjective in how symptoms are measured. You have lung functions, of which the flow volume curves can usually be done above 5 years of age. And below that, you would need more tidal volumes and not a forced volume exhalation, or you could do an iOS. We will talk about these tools as we go by further. If we look at the international guidelines, what do they state about monitoring? GINA, it talks about monitoring as an essential tool to maintain control and establish the lowest step and dose of treatment to minimize costs. And they want both the healthcare physician as well as the patient and parent to be involved in this using simple schemes or composite asthma scores. BTS also talks of the same, then talks of questions on symptoms, exacerbations. In addition, talks of checks for adherence, inhalation technique and exposures, and availability of self-management plans, and looking at the overall growth of the child. American NAEP talks in addition of peak expiratory flow rate. And largely, if you see, the guidelines talk similarly with some subtle differences. So what are these composite asthma control scores, like childhood asthma control test or asthma control test for older children or asthma control questionnaires? They have been validated most extensively, but they are largely have been used as a tool by the pharmaceuticals sponsored studies, and now have also therefore got into several of the guidelines for several reasons. However, they do not include exacerbations and future risk because they only talk of the current symptom control. Two of the composite asthma control scores, TRAC and CASI, have included the recent exacerbation, but these are largely tools for under 5 and not above 5, about whom we are talking today. So the good thing about these is they have a criteria validity. So any change in the composite measure does reflect change in the overall clinical assessment, and therefore has a good validity for taking clinical decisions. And this is just the pictorial of ACT and child. C-ACT. C-ACT has 2 parts because it's for younger children, something to be filled by child and parent. And obviously, when it is for such a young child, we are using pictorial or emojis and not something which is in terms of numbers. And this is graded, and you're good if you have 19 or more than 19 score. TRAC is something which we use for below 5, and it is administered to the parents. So these tools have been used, and what we prefer in our country is not the tools which I just showed you. Sorry, pardon me. My slides are So what we use is a symptom diary. If you look at the international guidelines, they say evidence to support these diaries to monitor uh, symptoms in clinical practice is limited, but some individual patients may benefit. But our own personal experience on this, though I must say that we have not conducted studies, that it works for a significant proportion of patients. It largely works for patients who are relatively adherent, and they on inquiring to them, they wish to use it because they think that it acts as a good reminder, particularly once the control is achieved. Because the diary which we use is not only talking of asthma symptoms control like cough, breathlessness, sleep disturbance in school, and it's a graded approach which you use there, how frequent the symptoms are, including nasal symptoms. It also talks about the drug which you use on that day and whether you used a SAVA or not used a SAVA, in addition to how many dose of ICS was given. So this kind of a short input which takes less than 5 minutes to account for last one day, once it gets into a habit, is able to also improve adherence. I must add here that we haven't conducted studies on it to say it, but this is what the expert opinion and the acceptance has been for us. In the NAEP, the American guidelines, there was a lot of thing about PFR monitoring, and which has gradually gone down because monitoring peak flow is difficult. It requires availability of a meter, a suitable place, it's unwieldy, inconvenient, or distracting. Not only that, the evidence also shows that peak flow it is counterproductive because it's not necessarily accurately reflecting the other indices of obstruction because it's partly or largely due to its effort dependency. So it may benefit some, but it does not it does not possibly even help majority of patients, and that is why PFR, which was earlier used in a traffic light pattern, red light, yellow, green with the management plan, is largely we do not something we use anymore. And in one of the studies where they compared symptom monitoring with PFR, there was a definite preference for symptom monitoring because of the ease it offered, and peak flow conversely is much more difficult. What about PFT or spirometry? FEV1 is an important measure of asthma control and therefore should be used as a monitoring method, but particularly so because significant bronchial obstruction may be present in asymptomatic asthmatic children. Chronic airway obstruction children are less likely to experience dyspnea as compared to those who have acute obstruction. So they do not, even with significant obstruction, may not report many symptoms, and that is where your symptom diaries may fail or may not be as objective. And it also sometimes happens that you have a lot of symptoms and it is not supported by your pulmonary function test, suggesting that it is something else which is causing this dyspnea, whether it is vocal cord dysfunction or maladjustment or what. However, a periodic assessment of PFT or a surrogate for younger children like iOS is something which is recommended by most guidelines, even an annual, just to see or reassure if for a child who's on continuing therapy, it's kind of a, when they're particularly controlled, it is kind of a factor which helps you put at ease patient as well as the physician to some extent that things are going the right way and there is an objective measure to what. The difficulty is that it is not universally available within our country, within our settings. A word about exhaled NO, which is one of the very important, extensively studied biomarker which can be measured in a non-invasive way and reflects both airway and tissue eosinophilia. The results are very variable, with only few showing a significant effect, such as reduced BHR. And the outcome measures are not consistent across studies. So meta-analysis do not support its routine use as a measure of control or to monitor asthma. So this has largely remained at fringe with tertiary level organizations, or maybe used more appropriately with steroid-resistant asthma or difficult to control asthma, where you need more objective measures rather than to be used routinely. So therefore, factors to consider for choosing monitoring tools would depend on several things, particularly frequency of follow-up visits, which depend on initial evaluation of clinical severity. It will need to be adjusted depending on response to intensity of therapy and intensity of therapy. The patients and parents' training and confidence in the monitoring and management of child's asthma, and that's very important. And that is why it will vary over time with course of illness. Maybe initially you would have 2 or more educational instruction sessions at a frequent interval, followed by reviews depending on control monthly or 2 monthly or 6 monthly. And that also varies with the facility you are working at. If you're a primary care physician for the child or a pediatrician for the child, you may like it every month or so to see, even for, they may be seeing you for needed for a prescription refill. While if you are a tertiary level organization who are dealing with those who are in full control, and they may not be, there may be difficulty in getting the appointments, and there perhaps once the patient is well controlled, it may be okay to do 3 or 6 monthly review. In India, we prefer to have more frequent reviews because of the attrition which goes down and the improvement in adherence which is seen with continuous reinforcement. Yes, those who would not come are non-adherent. Those who continue to follow up, even amongst them, having adherence of therapy in an appropriate way, that they have not, it is well documented that over a period of time, the way families use inhalation therapy, there can be deterioration and there can be a loss of control because of some steps being missed as we go by, because we either become overconfident or we leave it to the child because now it is no more a burning issue within the family because the child is not so symptomatic. And for these reasons, a repeated reaffirmation is definitely useful. And that's what would also have an impact on how frequently you see your child. Vulnerability of the patient, age particularly one, severity is also what will decide. People who are from more challenged situations, single mother, single parent, or broken families or poverty is something where also you would like to monitor more closely. The complexity of tools which you will use to monitor, as we say, the clinically relevant are few, largely symptom control, along with maybe a less frequent, but at least maybe a yearly PFT is something you need for most, unless until they have a difficult course where you may require more frequent and more objective tools to monitor. So when we do talk of asthma control, you have to talk of level of control in terms of impairment and level of control in terms of future exacerbation. But two important things which must always be involved is something on every monitoring visit is to look at treatment-related issues like inhalation and adherence and trigger avoidance, which are very critical, and also to look at severity and control of the comorbidities like allergic rhinitis, or if you have obesity or you have anything else going along with this GR, if they are not addressed, they also have an impact on asthma control and therefore would have an impact. Within the reasons for poor asthma control, looking at inhaler technique, compliance, and environment are three most important things, of which tobacco smoke in the family is very important. And this is something we can take as a small capsule, which is important in addition to talking of symptom control. So control-based asthma management cycle, therefore, as given by Gina, is something which goes on each visit. You assess or monitor, and based on the monitoring, you adjust the treatment upwards or downwards, and then you review your response, and that's a part of monitoring again, reviewing the response, and that's the full cycle of asthma management, which is very important for a good control. So the key to inhalation therapy need to be discussed at each time, where we demonstrate the right device, check, correct, and confirm with the family, and depending on the skills they have and what they know. So that's something which I thought is something which is very relevant for looking at asthma control. among children who have this disease. Thank you very much, and I'm happy to take any questions. Thanks.
And I request our delegates to post their questions, and all the questions would be taken at the end after Professor Andrew Bush's talk. Now, I would like to invite Professor Andrew Bush. A very warm welcome to you, sir. We are all waiting to hear your talk. The topic is what to do when asthma treatment is not working. Before that, I would like to share my introductory slide. And I know, sir, everybody knows, sir, and especially in the Indian respirology groups, but I would like to read his CV. Like I said, it's my privilege. Sir is Professor of Pediatrics and Pediatric Respirology at the National Heart and Lung Institute and Center for Pediatrics and Child Health, Imperial College. He's the foundation director of this. Sir is also the consultant pediatric chest physician at the Royal Brompton Hospital. Sir's research interests invasive and non-invasive measurement of airway inflammation in children, in particular, the use of endobronchial biopsy in the management of severe asthma and clinical physiology, especially the respiratory mass spectrometry. Sir has supervised a number of students, co-authored and written several papers, review journals, and lots of contributions in the academics. Sir is the Deputy Director of the American Journal of Respiratory and Critical Care Medicine. Sir currently is the Guidelines Director of the ERS, having previously chaired the Publications Committee. Sir is also the Emeritus NIHR Senior Investigator and was also the Chief Investigator in the Wellcome Strategic Award. So this could just go on and on. Sir was the first pediatrician to be awarded the British Thoracic Society Medal, which is awarded annually to someone who's done great contributions to the field of respiratory medicine. And he's been awarded the 2024 James Spence Medal and an honorary life fellowship, the highest honor of the Royal College of Pediatrics and Child Health, as well as being honored by being made the ERS Presidential Awardee. So that was quite something. So welcome to you, sir. And I would like to invite you for the next talk.
Thank you so much for that kind introduction. I'm not sure, are you seeing my slides okay?
Yes, yes.
Yes, sir. We are seeing
Thank you.
it in the first. Yeah.
So I'm having difficulties manipulating them. Never mind. I don't quite. So thank you for inviting me. I have no conflict of interest. I'm going to demonstrate, I hope, that if treating asthma is not easy, then as we've heard already from Verinder, the reasons likely lie outside the airway. I want to try to convince you that the right approach is a systematic assessment of the child rather than giving more treatment. And again, we've heard a very thorough presentation of the importance of this. I'll briefly discuss the new smart approaches. Should we ban the blue inhaler now? And briefly also the novel treatment approaches. But the main thrust of my talk is that most children just need to get the basics right and do not need exotic, expensive options. So asthma that is not responding, here's a background slide. And I'd like to draw your attention not to the fact that this is a monoclonal, but to look at these two columns. This is the number of asthma attacks in the year before and the year after the children were enrolled in a study. And note that on placebo, the attacks were cut to a third of their previous level. That's placebo. It's not a biologic. It's just simply attention to detail, more attention, as in the slide, the sort of things that Virender's been talking about. And although, yes, there was a further improvement with the biologic, the biggest improvement was getting the basics right. And my experience is that potentially reversible factors, some of which Verinder has talked about, will be found in 90% of those who are referred to me for expensive biologicals. Look for the big four. We've heard about them: adherence, 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 and adherence. And nurses, our respiratory nurses, find out far, far more than professors. I'm too old and easy to fool. And this is Rodin's sculpture, the KISS, a beautiful sculpture. And KISS stands for Keep It Simple, Stupid. Get the basics right before going beyond the guidelines. And it's something that old professors like me need to say to themselves time and time again. KISS, Keep It Simple, Stupid. So what should be our clinical approach to the problem? So if you've got problematic respiratory symptoms not responding to asthma therapy, is it asthma at all? Verinder mentioned diagnosis. What's the evidence that the child has asthma? Is there evidence for another condition? And we need not to be trusting about diagnoses. Does the child have a disease at all? What's the limits of normality? Is there positive evidence that the child has asthma? And is there evidence for an alternative non-asthma diagnosis? So here you can see a flow volume curve, and you can see straight away this is not due to asthma. The expiratory curve in the top panel is chopped off, and the volume time curve is more or less a straight line. This is a child who has large airway obstruction, in this case due to a double aortic arch. And we should be looking for tests for evidence that there really is asthma. And the utility of these tests may vary in different geographical environments. But I think evidence of variable airflow obstruction, are they atopic? Because in London, most severe asthmatics are atopic. Do they have airway inflammation? And I should stress, I'm talking here about, these are patients who have severe disease. I'm not saying that every child who wheezes twice a year needs all these tests. So if the patient, if the child, when you see them has a low peak flow, give them salbutamol. Does it improve? A field exercise test. Do they bronchoconstrict? 2 weeks monitoring of peak flow variability. I never go beyond 2 weeks because there's plenty of data that shows, in fact, that after that time, people get bored and stop recording. Is there a history of eczema, food allergy, or allergic rhinitis, or skin prick test and specific IgE sensitization? We've heard about a little bit about nitric oxide. It's certainly not a measurement that needs to be made in every child with asthma, but it can be very useful in a specialist asthma clinic. And also increasingly the peripheral blood eosinophil count, although I'm going to come to a caveat for that before it's applied across the world. So Verinder will have seen this in action. For those with really severe symptoms, we think they've got asthma, they have a multidisciplinary team assessment, and that includes adherence. Are they collecting prescriptions? We are able to do electronic monitoring. Do they have medications at home? And adherence is the major obstacle to effective management, at least in my practice, and the biggest single reason why treatment fails. And you can think of the PAPA framework, perceptions and practicalities. So practicalities, are they forgetful? Is the regime very complex? Are they being supervised? Is the kid not wanting to seem different? And also lack of understanding of correct usage, perception, perceived immediate gratification, you don't get it, worries about side effects. And this is just one panel from an electronic monitoring study. When we monitored these children with an electronic monitor, if their adherence is good, the asthma control and lung function improves and FeNO falls, as shown here. This is a child who's not been taking their medicine until monitoring, and then they take it. So here you can see this is a pretty adherent child, high FeNO, low FEV1 at the start, all normal at the finish. This child has not been taking treatment. You see those who have adherence who are poor, and there's no improvement with monitoring. They're either those who simply won't take their treatment or those with severe therapy-resistant asthma. And we need to know what happens when treatment is taken. And if adherence is good, but they're still badly controlled, then this is true severe therapy-resistant asthma. And the occasional ones who've got poor adherence and good control, these are the ones who've likely been overtreated in the past. So what about the SMART regime? So SMART, single inhaler for maintenance and reliever, budesonide and formoterol. Formoterol, a long-acting beta agonist with rapid onset, given once or twice daily and for relief. And GINA is now recommending this approach for using this reliever inhaler combination at steps 3 to 5. And I'd just like to show you a meta-analysis now in patients aged 12 to 17. The primary endpoint was time to first attack. And what you can see here, the adults are in red, the adolescents are in blue, that using the combined approach, they're much less likely to have an attack and they're much less likely to have a severe attack. And there's now been a meta-analysis of this approach, four studies, over 8,000 subjects, and they showed that if you used this combined approach, there was a longer time to the first attack, and you can see here the 4 studies, Sigma 1, Sigma 2, practical and novel start, 8,000 plus patients between us, and the time to first exacerbation was longer with this combined approach, and the rate ratios for a severe exacerbation were more favorable too. There was a slightly less good control of asthma, but it was less below the minimally clinically important difference. And people don't die of poor control, they die of asthma attacks. And this group concluded that for patients of 12 and over, this combined approach, rather than using salbutamol as reliever, was preferable. Shamefully, there's only one study in the 6 to 11-year-olds. It's an old study. Hans Bisgaard looking at budesonide formoterol once daily and as needed versus twice daily versus a big dose of budesonide. And the SMART regime was much more effective and it was safe. So the SMART regime is the dark bar, and you can see going from the left, all exacerbations, peak flow fall, extra treatment and hospitalization. The SMART regime is as good or better as the other regimes. And it's similar to in older children and adults, and there are ongoing studies in New Zealand and in the United Kingdom in this age group. So you've talked about adherence. What about the environment, cigarettes and vaping? I don't know whether in India you've been successful in keeping vapes out of your country. I would strongly advise you to do that. We measure urine cotinine as a measure of exposure. The environment, again, Verinder mentioned this quite rightly, allergen sensitization and exposure, and also psychosocial. Anxiety and depression is common. And sometimes, because you can get money for having severe asthma from the government, overcalling symptoms. So they have their evaluation. We put them in asthma plus comorbidities, difficult asthma and severe therapy-resistant asthma. And the team intervenes with a bespoke treatment pattern. And hopefully they then become no longer problematic. But the refractory ones, those who will not change the environment, those who will not take their treatment, or the obese with failed weight loss, they may need beyond guidelines therapy. So refractory difficult asthma, the differential diagnosis is exaggeration of symptoms for hidden or obvious gain, ongoing poor control and ongoing adverse exposures, ongoing poor adherence despite multiple efforts, and the differential is severe therapy-resistant asthma. They're fed up with taking ineffective medications, ongoing psychosocial factors, but importantly, in my country, most asthma deaths are in this group. So if the child is non-adherent, is the child non-adherent because is he or she treatment responsive, or because treatment doesn't work? In other words, what happens when we know the treatment is actually given? Either directly observed therapy or admission for directly observed therapy, occasionally intramuscular triamcinolone. And if they respond, as most of them do, we're using directly observed therapy at school or by video link on the mobile phone. If they're still not responding, and this is very rare, if they're still not responding when they're taking the treatment, then these are the severe therapy-resistant asthmatics. So what new treatment options have we have? And I want to stress again, I'm going to show you the data on the monoclonals. I want to stress again that most patients just need to get the basics right. So the one for which omalizumab as most is known is omalizumab. It binds circulating IgE and prevents it binding the high affinity receptor on mast cells and basophils. And you can see a little cartoon there, and it prevents eosinophil tissue infiltration. In my country, they have to be at least 6 years old. They have had to have had at least 4 oral prednisolone bursts or be on continuous oral corticosteroids before this treatment will be funded. And the dosing will depend on the child's weight and the IgE levels. In my country, it has to be between 30 and 1300. I underline 1300 because many of these severely atopic patients have IgEs much higher than that. They have to be aeroallergen sensitized, although this is probably not logical based on adult data. It's enormously expensive, around £20,000–25,000 per patient per year. And you can do so much with that sort of money just getting the basics right. It's administered in hospital to start with. Then I'll come at the end to our remote directly observed therapy program. And omalizumab, we know that asthma attacks, most of them school age, are viral triggers on an allergy background. They have a background type 2 inflammation. There's a small group, mainly preschools, that will have pure viral wheeze attacks. And there are some adults who've suffered from pure allergy-driven attacks. For example, the thunderstorm asthma, the pollen asthma. But omalizumab reduces airway type 2 inflammation and also augments antiviral immune responses. The evidence reviews, there are many of them, they're all saying the same thing. This is a very effective treatment. The Cochrane review showed there was reduced asthma attacks and hospitalizations with a reduction in inhaled steroid use. This was a systematic review of real-world study. Again, evidence of benefit, less steroids. Another real-world study, children aged 6 and over, better control, fewer attacks, a really solid evidence base. What else do we have? Well, in children aged 6 and over, we have mepolizumab, omalizumab that I've talked about, dupilumab, which binds the IL-4, IL-13 receptor, and tezepelumab, which is an anti-TSLP antibody only licensed in children aged 12 and over. So what about mepolizumab? And this is a really important lesson. Mepolizumab binds to circulating interleukin-5, which is responsible for the maturation and chemotaxis of eosinophils to the airway. And this was a double-blind, placebo-controlled, randomized controlled trial in children aged 6 to 14 who'd had at least 2 attacks in the previous year. They were on step 4 to 5 treatment and had a raised blood eosinophil count. And the primary outcome was the number of attacks treated with oral steroids. And they had nearly 250 patients complete the study. And if you look at that graph, the probability of remaining exacerbation free, you can see the blue line for mepolizumab and the red line for placebo are really almost identical. They really are not dramatic. If you look here, and they looked at the autumnal surge in asthma attacks as children went back to school, you can see that mepolizumab actually wiped out that surge in attacks. But overall, if you compare it to the adult data, and this is the DREAM study, it's plotted the other way around, so the total number of attacks, blue is placebo, the other 3 colors are mepolizumab, 3 different doses, and you can see there is a reduction of about 1/3 in attacks. And this is much more dramatic than in children, and it makes the point that we must not assume that children are small adults and extrapolate from children from adults to children. Dupilumab, it blocks IL-4 and IL-13 receptor. And this was a lovely study over 400 children, subcutaneous dupilumab. The primary endpoint was annualized asthma attacks. They did some fairly complex slicing up their patients into different groups, but the bottom line was the results were the same for all of them. In all groups, there were reduced asthma attacks, increased FEV1, and better ACQ score. And you can see here that the asthma attack rate, and you saw it in the first slide, was greatly reduced by dupilumab, and you can see here, but the annualized rate for dupilumab versus placebo in the two different groups, absolutely identical, a dramatic reduction. But do remember the biggest reduction in the was going from the year before the study and the year entering the study when there was more attention to detail. 10% increase in FEV1, better asthma control, and it was safe. But interestingly, there were more viral infections in the dupilumab group. And this is the open label extension, the excursion study, a 52-week open label study. The primary endpoint was safety, and 2/3 experienced at least one treatment-related adverse event, mostly viral colds, and the efficacy was maintained or better over at least 2 years. So here you can see you've seen the Voyage study in the first slide. If you know an excursion, the extension, there's an even further fall in asthma attacks, as you can see here. And you can see that the lung function, the red is the placebo group. When they started dupilumab, their lung function improved. Tezepelumab is an anti-TSLP antibody. TSLP is one of the epithelial alarmins. It's produced by the epithelium when sensing pollution and infection. And this was over 1,000 patients. And the primary endpoint was annualized rate of asthma attacks. And there was a significant drop compared to placebo in asthma attacks. And the exciting thing was the drop was seen even in patients who did not have eosinophilic type 2 inflammation. So looking this graph from the top down, whatever the eosinophil count, you got improvement. Whatever the pheno, you got improvement. And you got improvement whether or not you're atopic sensitized. So this is really very exciting because all the others require you to have raised type 2 inflammation markers. And this is helpful in type 2 low asthma. But we also need to, as another consideration before coming to children, induced sputum is a good marker in school age and adult patients of lower airway eosinophilic inflammation. But it's time consuming. It takes time to do. It takes time to analyze. But there's increasing evidence that the peripheral blood eosinophil count is a marker of eosinophils in the airway. And how do we interpret this? Well, my interpretation is that if there's no blood eosinophilia, there's likely none in the BAL. But obviously, blood eosinophilia may be driven by other atopic disease. Blood eosinophilia may be driven by parasites, particularly relevant in some settings. And we've also got to remember that the normal range for blood eosinophil count is very different in children and in adults. So you can see in this graph that the upper limit of normal for adults is about 300 cells per microliter, but it's much higher in younger children. We need more data. We cannot be relying on adult biomarker studies in children. Finally, I'd just like to mention one benefit of the COVID pandemic. We used to give all our biologics in the hospital. We give them obviously for severe therapy-resistant asthma and the hardcore non-adherent refractory difficult asthma. Normally, we're given in hospital with 2 hours post-injection observation. But in COVID, our pharmacists and nurses were very innovative. After 3 doses given in hospital with no side effects, they do the injections by video dots. They use a FaceTime or some other platform so the nurse can actually see in real time using the mobile phone that the injection is being given, and the mother has the reassurance of a nurse online ready to help if there's a problem. It's safe, it's liked by the parents, and there's no evidence of impaired quality of life. So where are we with monoclonals? Well, there's an absolutely shameful lack of pediatric efficacy and safety studies. We're relying far too much on adult data, including predictive biomarkers. Some potentially useful monoclonals are not available to us, for example, benralizumab, and others which don't work in adults are assumed not to work in children. Interestingly, we cannot assume that the eosinophil is always the bad guy. We're all familiar with the eosinophil in parasitic infection, but it's clear also from adult studies that too dramatic wiping out of the eosinophil by something like benralizumab may actually increase infections. And in that regard, it was interesting to see that dupilumab, the treated patients had more viral infections. So summary and conclusions. What are my take-home messages on this World Asthma Day? Most children with asthma respond very well to low-dose therapy if it's taken regularly and correctly. And if they don't respond, think, do they have asthma? If they are not responding, do not keep on giving more and more medication. Ask yourself why not. And the answer will usually be either wrong diagnosis or poor adherence. Get the basics right. For the genuine severe asthmatic and those with refractory difficult asthma, think about the new biologics, but such children are very rare. And so finally, I'd like to thank a large number of funders, colleagues and supporters, including especially the Brompton Difficult Asthma team. I'd like to thank you for listening and leave you with this picture of my 8 wonderful grandchildren. Thank you very much for your attention.
Neetu, you need to unmute yourself.
Unmute करिए, please. Please unmute, Dr. Neetu. Please unmute.
Sorry. Thank you so much, Professor Bush, for such an enlightening talk. And now we have some time for questions. So my first question is for Professor Varinder Singh. Sir, this is what is the practical way to assess control of asthma in my clinic tomorrow if I need to start treatment at the appropriate step in a treatment-naive child or step?
It's always the symptoms. If they are, that's what your starting point is. You may or may not use a score. It's not essential that you have to have an ACT test with you or a questionnaire, because many of them are commercialized and you can't use them without permission. So they are more relevant for when you're doing studies and you want to have objective measure to compare or non-compare. In a routine, I would say looking at symptom control. Now, whether you do that as on a recall basis when the patient comes to you, how the last month was, or you do on a daily symptom diary is something on which there is no clarity, because I, for one, go for a daily symptom diary. But if someone does not maintain a diary, the alternative is to ask a composite measure of what happened. There are pluses and minuses of both, and which I had already addressed in my talk.
Okay. Thank you, sir. Professor Bush, the next question I would like
Bush
to
has
ask you.
raised his hand. He has something to add.
Yes, I completely agree with you, Varinder. One of the things you rightly stressed is also measurement of risk. And of course, you can have patients whose symptoms are 0, but are still at risks of attack. And we're increasingly looking in the UK, and I don't know whether this would be relevant in India, that a combination in an asymptomatic asthmatic patient, if they have a raised nitric oxide and a raised blood eosinophil count, their attack risk is much higher than than you'd expect. Again, this is something that needs more testing in children and more testing in settings other than London.
Indeed, something I wanted to ask. Sorry, Ritu, I'm jumping.
No, sir, please. We are enjoying the
Is more on the debate around smart therapy, because it's one product, one particular formulation, which is a DPI, is not an truly an MDI spacer with a lot of oral deposition. Is that by itself good enough for us to change below 12 years? Because Gina has been pushing it below 12 years, but looking at the usage in our country, where either there is hardly any use or there is an over usage of SAVA and LAVA, come what may, depending on the anxiety of the patient. Giving an ICS LAVA combination in the hand of patient, which may not be in a regular adherence, we somewhere perceive a risk, given that the evidence is not so robust. Would you like to comment on that?
Yes, I mean all the 4 studies I showed you are in a sort of Western urban type environment, and I must stress that I would be very hesitant in applying it uncritically to asthma in India without further studies. The reasoning is this: as you know, one of the major risk factors for bad asthma attacks and asthma deaths is using too much short-acting beta agonist and not taking your inhaled steroids. The idea of this combination therapy, and we do have it available in a metered dose inhaler and spacer, is if you take away the blue inhaler, they cannot fall into that trap of just puffing away more and more blue inhaler. The evidence is much weaker in the 6 to 11 age group. Richard Bees is recruiting for a big study in New Zealand, and Louise Fleming here is about to start a big study in the United Kingdom. We certainly need more evidence. But there's a sort of asthma paradox, though. Nobody in their right mind would prescribe long-acting beta agonists without an inhaled steroids. That would be completely negligent. But yet at step 1, we're happy for them to take lots of puffs of short-acting beta agonists without steroids. Doesn't seem logical. The other safety issue people have said is, okay, in that case, are they going to take too much steroid because they're using this so much? But the evidence is they actually get better outcomes without more excess steroids in the 12 and over age group in the environment and setting in which it's been studied. A challenge for the young investigators listening to this: get out there and do a study in India.
Yeah, thank you so much, sir. We'll move to the next question, which is for Professor Bush. Sir, your comments on the use of azithromycin.
Yes, so azithromycin in children, the evidence that it's actually useful in eosinophilic asthma is really very weak indeed, and the ERS task force felt that there really wasn't enough evidence to recommend it. Again, the data are sort of North American, UK setting. It may be different in India. I have to say, if the study I didn't show, there was one that said, okay, if you have a symptomatic on inhaled steroids and long-acting beta agonists, is it better to add montelukast or is it better to add azithromycin? The study ended in futility because they couldn't recruit, because those who are symptomatic on inhaled steroids and SABA and long-acting beta agonists either didn't have asthma or were not taking their treatment. So I really would caution, piling in more and more treatments. Actually, you need to step back and think about some of the basic things that Virendra and I have both discussed. And it's interesting, the perspective. There's a lot of similarities. I think you'd agree, Virendra, between what trips us up in India and what trips us up in the United Kingdom in terms of adherence and stuff.
Yes. Professor Varinder, sir, how frequently do we need to do PFT, that is spirometry, for monitoring? This is from Dr. Partha.
So, if you have a well-controlled child with you and uh, there are no symptoms at all, and then possibly at least at least once a year, more frequently if it is available to you before that, and the child is able to do. Otherwise, unless until you are running into rough area where you aren't sure the symptom reporting and your clinical signs are not going hand in hand, and you are debating on the control, then it may be required. Then that's a diagnostic issue. It's not for monitoring. Then you are looking at something which is uncontrolled. So routine monitoring, you're looking at trends over years and to convince that, okay, whether the therapy is working or not working, or look at any red flags that where the reporting of symptoms may not be correct. I would say 6 months to 1 year, at least once annually should be done.
I certainly agree with that. And the other point is that there's increasing interest in lung growth trajectories, and if the child is gradually slipping off their lung function centiles, you want to know the reason. You want to know the reason why. And one of the things you mentioned about risk is risk of not growing your lungs properly. And I think that's why I absolutely agree. You want to do at least an annual spirometry if you possibly can.
Yeah. Okay. So, sir, we are coming to the next question. This is for Professor Bush. Sir, this question is labeling asthma in infant. How can we be sure? And how do we tell it to the parents?
So this is a really important question. And one of the things, of course, which we didn't define is what do we mean by asthma? And the Lancet Commission that Ian Pavord and I co-chaired defined asthma as a clinical syndrome of cough, of wheeze, chest tightness, breathlessness, sometimes cough. And underlying, it's an umbrella term, just as there are many different arthritises, there are different asthmas. And you then want to say, okay, if the child's got wheeze and chest tightness, yes, the child has asthma, but is it the sort of asthma that responds to inhaled steroids? And there's increasing data, again, not in an Indian context, but there's an increasing data that a raised peripheral blood eosinophil count is predictive of a response to inhaled steroids and a marker of risk of wheeze attacks. So what I would say to the parents, okay, your child at the moment has asthma, but that does not mean the asthma is going to be there for the rest of the child's life. We're going to test aeroallergen sensitization and blood eosinophil count, which we're now doing on a point of care skin prick test, to see if they've got the sort of asthma that needs inhaled steroids. And we'll keep monitoring the child because, as we all know, the patterns of disease change in children as time goes by, and you want to, and as Verinder again stressed, get more severity, more or less. It changes over time, and you need to adjust your treatment over time.
I hope everybody's convinced, and that really helps because this is a difficult situation for all of us.
It's a very difficult situation.
Difficult,
absolutely.
Yeah. Sir, Professor Verinder, sir, your experience with digital PEFR monitors. So your comments.
So it's a question of what you're reading at. But what you're reading is coming from an individual who has to blow hard. Whether it is a digital machine or a manual machine, it does not in any way, to my mind, has an impact on how it is done. So it may be more accurate, maybe. Yes, one possibility. I do recall a couple of studies on that. But what I can't say is that whether they will give you more information. So if you're looking at a variability for a short time and you're sure the patient is doing it well, possibly, yes, one way of looking at it. But I was a big fan of PFR in early 2000 to 2005 with that, yellow, green, red traffic light system of self-management, and we tried it. And then there were some 15, 20 patients with us who were always at trouble. When you looked at their PFR and when you looked at them clinically, there was complete mismatch. And that was something which taught us that, okay, these numbers are just mere numbers, and you have to look at the overall pictures. And gradually, when we discuss with other, friends who were peers in different areas, they had everybody has a similar story to tell. So, as Professor Bush also mentioned in his talk, that if it is for a short time and you have trained and they are able to do it, for a diagnosis, if you're looking at PFR variability, you can't do a BHR. Perfect, maybe you can use it. But for long-term monitoring, daily PFR charting, morning, evening, oh, trust you me, it doesn't work. It doesn't work. We have burnt our fingers and then left it. But it's been 3 decades. At that time, there was no digital available. But I don't think there's going to be any difference unless Dr. Bush has a different experience, I'm sure.
Well, you're right. The only advantage of an automatic digital recording is you know whether they've actually done it or made up the number. And there's interesting studies when they've compared the digital with what's written on a piece of paper. And you've all done this thing when they say that all the marks are in the same pen, or they say to you, "Oh, do you want next week's peak flow chart as well?" Because they've done that. Yeah, I completely agree with you, Vrinda.
The child was little bored. He protruded his tongue one time. Next time he decided not to protrude his tongue or not make a good seal, and there goes your PFR out of the window. So there's too many variables within this test, which can have an impact. So if you have a test where repeatability or reproducibility is affected more often by the major difference you are going to detect, then you're more often going to land into it. That's my understanding.
Yeah, agreed.
Yeah. So there are a lot of questions pouring in, but I think we have time for 2 questions and then a quick, winding up statement by both the faculties. So the first one to Professor Bush. So you had mentioned about the oral prednisolone burst therapy. So when do you recommend it, and what is the dosage that you recommend?
So for an asthma attack, acute asthma attack, that's when we would use it. I don't think I've got a single child now on continuous alternate day long-term steroids, and we use 1 to 2 milligrams per kilogram, with the top dose 40 milligrams would be, but these numbers are to some extent arbitrary.
So
I would rather look at an alternative diagnosis.
Okay.
Oh, if absolutely. If you're thinking, maybe I misunderstood the question. If you're thinking this asthma is so bad that they need oral steroids, absolutely, you're 100%. Look for an alternative diagnosis.
Okay, Professor Varinder Singh, so last question. So the budesonide formoterol combination. So 100 BD or 200 OD, which is better in children as far as control is concerned, by Dr. Mamta?
You see, to begin with, I prefer BD dosages. Though OD dosages are good, they allow you a better control. But then, to begin with, I prefer to give twice a day. If there is any error or any difficulty, in my mind it works better, because if the child, did not inhale adequately, at least some dose is going. Once they've achieved a good control and you have some margin there for even some erraticity, then OD helps in adherence. So that's the advantage. So that's how I would pick and choose.
Okay, Professor Bush, your comments?
Yeah, I agree, and particularly in teenagers, we're increasingly now using something like Relvar, which is a 1-day preparation because it's very, very long acting. Because maybe Indian teenagers are better behaved than English teenagers. They couldn't be worse behaved. If I get them to do something once a day, then that's a success story.
Okay. So we come to the end of this session, and before I hand over to Dr. Jagdish Goel, I would request Professor Bush for his closing comments. Just a quick recap of what you said, sir.
So the quick recap is KISS. Keep it simple, stupid. Get the basics right. If you get the basics right, 90+% of asthma will melt away.
Thank you so much. Professor Varinder Singh, sir, a quick closing comment from you.
So I would say that just reiterating what Professor Bush said, keep it simple and smart. And the smart is not necessarily smart therapy. Smart is remember what is to be done quickly and efficiently. And do not get too much bogged down by what's a new toy available, what is the new flavor of the season. Forget it. When we say keep it simple, the old tested methods, clinical methods, still hold valid and will work for large variety of our patients. Yes, you have a blip on your radar who is not following the regular path. Absolutely, refer them to a facility where all these tests can be done. They could be under a different set of regulations. But having a regulation chart for each and every child with asthma, it is not cost effective, not time effective, either for the provider or for the patient. So large variety of patients can be managed with simple tools. You do not need, just because a tool is available, it doesn't mean it has to be used. Yes, it can pick up some exacerbation or risk earlier, but you have to see a patient who is behaving like that. No, I'm not going to do of 1,000 children. What is my number needed to treat? Where I'll pick up 3 or 4 of these. Yes, I have a group of a cohort who's not doing well, who are otherwise at a risk, and I'm not able to identify within these which has responded or not responded to my therapy. Yes, these tools are very relevant there. So employing all the tools which are available to us in a judicious way is important. I'm sorry you wanted a short answer, but this
No,
was
no, sir.
something.
We are getting a lot of clarifications, important clarifications, and one could just go on listening to you.
Thank you.
So I now hand over to Dr. Jagdish Goel for the last comments. Over
Thank
to
you, Dr. Neetu. So on behalf of IAP National Respiratory Chapter, I would like to thank both esteemed speakers and today's moderator, Dr. Neetu. And I would also like to thank all delegates for joining us today. Thank you once again. Good night. We'll see you. Thank you. Bye-bye.
Thank you. Thank you once
Thank
again.
you,
And good
Andy,
night.
and hope you are able to make to India in November.
Good night to all.
Good night, everybody.
Thank you, sir. Thank you. Thank you. Good night, sir.
Thank you, sir.
Good night.